This podcast is for informational purposes only and does not dispense medical advice. Always seek the advice of a physician or other qualified health providers if you have any questions regarding a medical condition. Never disregard professional medical advice or delay in seeking such advice because of something you have heard on this podcast. Welcome to a show that we like to call Prostate Cancer Real Talk. Did you know that in the U.S., 1 out of every 8 men will be diagnosed with prostate cancer during his lifetime? 1 out of 8. And black men are 50% more likely to develop prostate cancer in their lifetime and twice as likely to die from the disease. But hey, we're not here to quote statistics and tell you how tough prostate cancer can be. Rather, we are here to create a supportive community of survivors. A place where we can discuss the real-life coping methods from the perspective of a married couple who are living through it day by day. Our hosts, Elle and Shay. This is Prostate Cancer Real Talk. Today we are joined by Dr. John McGill, who is a urologist specializing in robotic surgery at Phoebe Urology in Albany, Georgia. He received his training at Northwestern University's Feinberg School of Medicine, the Cleveland Clinic, and Case Medical Center in Cleveland, Ohio. He has over 15 years of experience in urinary conditions, including kidney stone removal. In addition to his clinical work as a urologist, Dr. McGill is an active advocate for the dissemination of life-saving information about prostate cancer. His advocacy includes being chair of the R. Frank Jones Urological Society's Community Prostate Health Fair, which is a series of regional events held in conjunction with the American Medical Association. These prostate health fairs go into communities to connect people with resources that they may not be aware of, including healthcare professionals, free PSA screenings, research institutions, hospitals, and more. Dr. McGill joins us today to further his work in making a difference in health disparities within the medical community. Ellen Shay, take it away.
So, Dr. McGill, you mentioned Tuskegee, okay? And a lot of people will say, well, you're not going to Tuskegee me or whatever. But when you ask them to explain what they mean when they say Tuskegee, they can't do it. Okay. Okay. Right. Right. You're afraid of something you can't even explain. Okay. So for those of us or some people who are listening are not familiar when we say Tuskegee and we're talking about Black people and we're talking about clinical trials and whatnot, can you talk a little bit about the Tuskegee story and why it is such a hurdle for people to get over?
So the Tuskegee event was essentially a syphilis study that was looking at, it was supposed to be a public health service study where Black men were being monitored. It was about 40 years. I think they started in the 30s. And they were supposed to be monitored and treated, and we were supposed to see how to treat syphilis. But there were eventually was found out that the study was not being used to look at treatment. It was actually being used to just monitor the course of disease. So the men were given essentially fake medication. They weren't actually being given what would have helped them to get better from the syphilis. And then the syphilis developed, and that's how we learned about secondary and tertiary syphilis and things like that.
So they were actually given a medication, but it was not
what they were told. Yes.
The medical term for that is a placebo. Am I correct?
That's correct. I was trying to steer away from that.
Okay.
Yes.
But
yes.
Okay. So they were given a false feeling of being treated when they were really just given a fake or placebo treatment. Yes. Okay, yeah. And I'll stop there. I don't want to go on.
That's essentially it. And so what the sequelae from that has been devastating in the Black community, because now we have a situation where the trust is totally broken as far as research is concerned. And so that's one of the things that comes up, and it's one of the things that you have to address early on. Transparency is very important from the beginning, even if there's no discussion specifically of this study. And there's an underlying undertone regarding it. And so typically whenever I lead discussing anything related to research or clinical trials, I start with transparency. I start with transparency, and I start with trust, and I'll let them know, hey, I'm not going to let you get into anything personally. I'm not going to let you get into anything that's going to hurt you or not help you, because that's not why I'm here. And so I think that's why we need more Black doctors. That's why we need to close these disparities gaps, because without those conversations and without that one-on-one, you're not going to win this battle. I'm not a believer in large crowds. I think most great change happens in small groups. Because most of the time you've got a few change agents that go into spaces and they change those other crowds. So I don't look for, 300 and 400 people to have that discussion. I'd like to have 5 or 10 champions like I have here in my town, and let them go around and disseminate the information, and go and make disciples, so to speak, and win people over. And so now I've been doing work down where I'm at, related to this for about 5 years now. And now people come to me and they say, well, I want my PSA because I had a person who was at one of those events and they got their blood drawn and it was elevated. And so I'm smiling big, because now you're advocating for yourself. We've gone beyond this Tuskegee issue, and now it's personal, which is what we want.
Just a reminder, to ensure that you stay up to date on the latest episodes from Prostate Cancer Real Talk, don't forget to hit that subscribe and like button.
In my personal experience, when I'm at social events and whatnot, I guess people are, oh my God, here he comes. He's going to start talking about prostate cancer. So I try not to get disinvited to parties and stuff, because, so we're going to church tomorrow. We don't need a sermon on prostate cancer. But this one particular event was recent, that we were at. And it just so happened that we got around a collection of about, 5 or 6 guys, and they were Black, and we were all around the same over 50 age group. And we were talking about, and I don't know exactly how it came up, but we were talking about PSA and getting tested and whatnot. And I was asking a couple of guys, well, did you get your PSA test, and what was it, whatnot? And the thing that stood out in my mind was the absolute lack of understanding about PSA and what you should be doing and whatnot. How can we improve that, where we're getting guys to understand, hey, it's a simple test. You should go in and get it done. It's a blood draw, and you actually, the physical exam as well. But how can we improve the level of education? Because to me, the lack of understanding is striking.
That's a great question. I think one thing that's important is that the person be open to information. And if I don't have the relationship where they view me as a person that would inform them, it's not going to get very far. And so I think it has to come from trusted voices, which is why we've keyed in on pastors, clergy, and barbers. The barber literally has their head in their hand. They have a captive audience. And he may not come back to me in 2 weeks, but he's going to get his fade in 2 weeks for sure. He's going to get his tape up. He's going to get his line in 2 weeks. And when he sees his barber, when his barber says, brother, did you go get that PSA? It has impact. It actually makes a difference. And there are going to be some men who go, shoot, I'm getting my hair cut on Friday, and let me go get this PSA from LabCorp on Thursday, because I don't want them to ask. That's what we want. Yes. We need trusted voices. And so I think it's important to train leaders within the community about the importance of this, and then let them disseminate it and spoon feed it to the community in the way that they need to, because the leaders are accustomed to engaging and understanding what the needs are of the community, and can present it in a way that might be more palatable. But you're right, El, it can be a little surprising at 2024 to see how much this is not being discussed and how uneducated a lot of brothers are on it. And so I think having that information come from a trusted voice makes a difference.
And you just validated a concept Shay will verify, that one of the initiatives that I am interested personally in pursuing, and that is to recruit barbers into the prostate cancer discussion, because like you said, they have a captive audience for 20, 25 minutes every 2 weeks. All right. And if we can get the barbers behind this and to understand that, you know, they are a great resource. I mean, if you want to find out what's going on or just have a great dialogue, go to the barbershop.
That's right.
And, you know, there's a lot that goes on there. And so that's something that I have that's been in my mind to initiate. And believe me, when we get it going, we will be coming back to you, sir, Dr. McGill, to work with us in some capacity as we develop that. Shay?
I just want to say thank you, Dr. McGill. I wanted to follow up on one point that you made, and we don't really talk about it a lot on our podcast. And you mentioned radiation, and I believe you said seed.
Yes.
Okay, so we just talk about surgery because that's what Elle had. So can you explain to the listeners that procedure or that process that they could take? Because Elle had surgery and that's what we talk about a lot. So talk to the listeners a little bit about that.
So there are a few types of radiation. Two of the broader categories is radiation from outside the body. And then there's radiation from these little pellets called seeds, or brachytherapy, we call it. With brachytherapy, it's very similar to a certain type of biopsy. We basically put a little grid. We go to sleep. You won't remember anything or feel anything. We put a little grid on the perineum, or the taint, the area behind the scrotum, between the scrotum and the anus. And we map out where these little seeds that have radiation on them go, and we put them within the prostate. It gives off radiation and it kills the prostate cancer from within the prostate. Sometimes we put a few on the outside as well. And it's a outpatient procedure, usually takes about an hour and a half. There are in the right patient, men can do very well with that. And then there's the other versions of radiation, and there are different types. I'm just going to talk about external beam, but there's some subsets within that where a person would go in usually 5 days a week for about 30 minutes, anywhere from 6 to 8 weeks, depending upon the location, and have radiation from the outside. Now, this is not the way it used to be 30, 40 years ago, where they would radiate your entire belly and all the way down to your knees and all that. They're able to, I'm exaggerating, but it was not.
You just scared the heck out of me even thinking about it.
Can you tell I'm a surgeon? I'm a little biased. I didn't talk about surgery like that at all. I said, oh, it's great. That's why I tell people.
No, we're going to have a radiologist on in a couple of weeks. Maybe we can have a battle.
That's right.
Versus, right?
Yeah, versus. Radiation versus surgery. Battle it out.
But they're very specific and able to focus specifically on the prostate. But even with that, and with those advances over the decades, you can still hit areas that are around the prostate. So the bladder, the rectum, and the urethra. And so when you get issues, a lot of times it's from those areas.
Okay. And one last follow up. And the last thing you mentioned, active surveillance. So why would a person be put on that?
Active surveillance is an option for men who have low risk, low volume prostate cancer. So in the men who have the kind of cancer that we don't worry about, the kind that doesn't spread, we will typically say, you don't necessarily need surgery, radiation, or any specific treatment right now, but we should probably watch you a little closer than other men. One thing that's important is that we get a confirmatory biopsy within 1 year. And that's to prove, so we'll get a second biopsy. That's to prove that that man is actually a candidate for active surveillance, because we don't want to have maybe gotten close to something that was aggressive and got this report back and maybe missed something that was a little more aggressive. And so now we're treating it like it's a Chihuahua when it's really a Rottweiler. Mm-hmm. And so what I do is I and typically most urologists, they'll do it within a year. I do it within 3 to 6 months. That way we have, because I'm real big on, I don't want my patients anxious.
Yes.
I do not want them fearful, because it's like you're losing days. You can't even enjoy your life because you're worried. Oh, should I really be on active surveillance? Should I have gotten my surgery? Should I have gotten radiation, et cetera? And so I like to get that information a little sooner than later. And so typically with active surveillance, we'll do a PSA every 6 months. Every once in a while, you may mix in an MRI. And once we've confirmed that, yes, this is low risk prostate cancer, low volume prostate cancer, we may not biopsy again for another year, 2, 3, or 4.
Okay.
I have a follow-up question on active surveillance. So as Shay mentioned, we elected surgery, and that was primarily because of what my Gleason score was 4+3, which was a 7, which I interpreted to understand to be a moderately aggressive form of prostate cancer. And so I had the decision to go between surgery or radiation, and we collectively, with the counseling of our doctor, decided on the surgery. But what I always wonder about active surveillance is, for a person that chooses active surveillance, do you ever see it maintaining the PSA level maintaining the same level for a extended period of time, or it certainly doesn't go down? Okay, so my question is, do you ever see anybody on active surveillance that kind of just stays on it because the PSA level stabilizes? To me, that it sort of doesn't make sense, but maybe you can help me understand that.
No, you're absolutely right. Most of the time, it doesn't change very much. What we find is that by about 5 years, a majority of men will go ahead and get something done, not because it changed, but because they got tired of coming in, and they got tired of the PSAs, and they got tired of talking about biopsies. And that was one of the reasons why in the last 5 years or so, before we used to do biopsy every year. It was routine. If you got your biopsy on June 15th, that's your biopsy date moving forward. Well, we've kind of softened with that because we're realizing it's not very aggressive if it truly is low risk, low volume prostate cancer. But we do have people who it doesn't change very much. The only thing I worry about with that group is every once in a while you'll get someone who feels comfortable and they go, well, it didn't change. I'm not going to go this year. Mm-hmm. And that's one of the reasons why I'm not in the camp of changing this from being called prostate cancer to something else. So there are some urologists, because this is not thought to be aggressive, they want to change the name where it's not considered cancer. I think that's problematic, because if I tell a brother you don't have cancer, technically he may not come back. And so although it is not as aggressive as a 4+3 or a 4+4, we still need to keep an eye on this. We still need to make sure that we've got this under control, and we need to make sure that there isn't some little subset of 4+3 developing. And so, yes, you do have people who the PSA stays the same, but we try to encourage them to kind of stay the course.
I'm going to be really transparent here. So I was 4+3, and Shay will still occasionally ask me, was surgery the right option for you? And so after discussing it with my surgeon, the 4+3 to me was evidence that it was moderately aggressive. And two things led to my decision for surgery. First of all, I wanted prostate cancer out of my body. I just wanted it gone. Mm-hmm. Okay. And then the other thing is that when I learned that radiation was sort of like a one-way street, once you started radiation, the likelihood of you being able to have surgery down the road was minimized greatly, if not totally eliminated. So for my own personal satisfaction and the satisfaction of my wife, Shay, can you comment on my 4+3 Gleason score and the decision for surgery?
I would first of all say I think you made the right decision.
Thank God. Thank you. Okay.
I'm going to leave with that.
Okay.
When we make that decision, we typically will look at the whole picture. How healthy is the person? How young is the person? What's important to them? Et cetera, et cetera. In a young man with a 4+3 = 7, we tend to lead towards surgery in a young man. Now, if you're talking about a man, in his 70s, you may lean him another way. If he ends up getting diagnosed and he's in, let's say he's 76 or 77 or something like that, you may lean him another way. Because if he does have a recurrence, it's going to happen in the late 80s. And so then you have to ask yourself, well, what's the likelihood that this person is going to make it that far? And if they do, do we think that they'd be able to enjoy their lives if they have leakage, if they have, the issues related to surgery, et cetera, et cetera. And so in a young person, like you said, I think you put that perfectly. Radiation is oftentimes looked at as a one-way street. You really don't want to go back behind that, but you can go back behind surgery with radiation if you absolutely needed to. And a 4+3 is enough to respect. So I think you made the right decision.
And honey, in all fairness, I'm very analytical, so I do ask questions, but I said that we made the right decision.
Mm-hmm.
But I always help,
She will still occasionally read something. Okay.
Yeah, I do a lot of research. A lot of research for our podcast. So, you read new stuff all the time. And so then I'll, have a question,
She said, honey, are you sure you made the right decision? So yeah. I'm glad that you made that assessment, Dr. McGill. We're already friends and buddies, so we even became closer just now with that answer.
Yes, sir.
Shay, as we depart our time with Dr. McGill, do you have any follow-up or any final thoughts?
No, I just want to really thank him for being on the podcast. It's a new voice to our podcast, and I know the listeners just going to absolutely love you the same way we did, because you brought such great, fresh energy to the show. So thank you for being on the podcast.
Don't forget to subscribe to our YouTube channel and like this video to keep seeing more content like this from us. It will also benefit YouTube's algorithm, helping to introduce our content to others who may need it most.
And before we depart, Dr. McGill, again, I want to thank you as well. And you mentioned that, you and the Off-Frank Jones Society do these community outreach events and what have you. So in conclusion and in summary, we have a chance for you to address the listeners and the people who are interested in this topic. And so what final thoughts would you like to share with them as a summary of our visit today, and any advice that you have for them going forward?
Sure. First, I wanted to say thank you for this opportunity. It was great hanging out with y'all and having a discussion about something I'm so passionate about, and y'all are clearly passionate about. To the listeners, for those that are that have a family history of prostate cancer and Black men, please have a discussion with your physician about getting a PSA. Please do not let the rectal exam keep you from having the discussion. You don't necessarily have to lead with a rectal exam. You don't have to kiss on the first date, but I need that blood draw. We need that blood draw to get a baseline of where you're at if you are over 40 and have family history or are Black. It is very important, because it is very clear that when we catch this early, men do better, and we want you overall to do better and have a good quality of life.
Dr. John McGill, we thank you so much. And again, we're both Northwestern grads. I didn't go to medical school, but I went to Kellogg, the business school. And so, and also I was treated at Northwestern, and, we've had my surgeon on, we had your friend and associate, Dr. Adam B. Murphy,
yes,
from who I understand was your mentor.
Yes, he was. I love that man.
So, we're of kindred spirits. So we thank you for your time, and we look forward to working with you and the R. Frank Jones Urological Society going forward. And thank you again for being with us today.
All right. Thank you. Thank you. Appreciate y'all.
Thank you, Dr. McGill. Thanks for being on the podcast.
All right. Thank you.
To find out more information on the guest you just heard or previous guests and a list of Prostate Cancer Real Talk episodes, visit our website, prostatecancerrealtalk.com. And if you have a question, comment, or if you would like to share your story, send Elle and Shay an email, ellandshay@prostatecancerrealtalk.com. That's L-E-L and Shay, S-H-A-Y, @prostatecancerrealtalk.com.